In the United States, we have disparities, and it's unacceptable. SDOH is a social determinants of health. It's where people work, live, play, and pray. Zip code analyses can tell you who wins the presidential election 5 minutes after the poll closed. You can do the same with cardiovascular morbidity and mortality. You can look at counties and zip codes and fairly accurately predict the rates of diabetes, hypertension, heart disease.
American Heart Association, Family Heart Foundation, most professional societies now recognize that social determinants of health are crucial.
The American Heart Association in 2020 convened a committee to address the fact that despite decades of research in cardiovascular disease, including lipid management, and also we've known about disparities now for decades, these disparities persist.
We know that in the US, the population of Black people has diversified. Not only do we have African Americans, we also have Afro-Caribbeans, we also have African immigrants, right? People who migrate from Africa to the US.
We know that even within the Black group, the African Americans, there are huge disparities by education, by income, by geography, even by zip code. Same when we think of Hispanic and the Latino community. We know that there are very big differences between Mexican Americans and Cuban Americans and Puerto Ricans. And so the notion that we can look at Black-white differences and design studies that target race and ethnicity, that's something that should be gone. This is the 30th anniversary assessment of the Heckler Report. I want to point your attention to the most recent disparities that were found around 2015, the time of the analysis. For cancer, disparities were 50% worse than when the Heckler Report was presented to Congress. For cardiovascular disease, it was 33% worse. For substance use, no change in the disparities. Care for diabetes was 78% worse, and you see the rest. And I highlighted the last column in red because that was where they tried to answer the question, what was the disparity change? Now, you might say, these are data from 2015. Of course, we've got to be doing better. Well, we have data from 2022. Again, using federal government data, but all of you are familiar with other data that shows that, yes, we've made remarkable progress when it comes to cardiovascular disease, but we have really failed in terms of closing the gap of the disparities. We need to have an anti-racist stance and make sure that we're doing things the right way.
The number of persons reaching an LDL less than 100 for Black and Asian Americans is less than when compared to white or Hispanic Americans. These nuances, these differences are hard to explain based on any genetics. And in fact, in people who have FH, women, minority populations, lower education, lower income are less likely to get a PCSK9 inhibitor. When they get it approved, less likely to get it filled. I really think that there's a huge bias against women in the system.
It's really important for us to raise awareness about heart disease in women and focus on genetic lipid disorders. The reason for this is because of the historical perspective that we've had in medicine that women are at lower risk and the 10-year lag that exists in treating women and preventing heart disease. It's fascinating, even women who have already had a cardiovascular event, a heart attack, somehow still providers don't recognize the need for aggressive and early treatment.
Women who are 34% less likely to receive any statin therapy. And it's even worse when you think of high-intensity statins.
So when it comes to the treatment of women, there is a number of concerns on the provider side. One, a perception that they're not at very high risk, and therefore that they can wait perhaps even until the menopausal years to start treatment. There's some concerns about pregnancy and being on medications. So historically, there's been an entire avoidance of medical therapy during what we would term the childbearing years. Women tend to be care providers who sometimes put themselves at the bottom of that list. And they don't also advocate as commonly as men perhaps do for their own health. There are a lot of things that both, we need to start to recognize in educating clinicians better and removing those biases, but women can also really take control and know their numbers, know what appropriate treatment is, and really put themselves first.
We need to educate clinicians that whatever they've been doing for years may not be adequate to control the ravages of FH and elevated lipoprotein A. Patients need to be tested, then informed, diagnoses made, and where pharmacotherapeutic agents are available, they should be applied equally, regardless of race, ethnicity, sex, gender, socioeconomic status, or geography.
If we restructure our healthcare system to provide the highest quality of care to marginalized populations, we'll do right by most of our patients.
Most of you know Martin Luther King from the drive for voting rights, social rights, but he also said of all the forms of inequality and injustice in healthcare is the most inhumane. We just need to do better.